So next slide. 2 to 8 milligrams. I mean, that would be like microdose, right? Yeah. And that's the thing. Yeah. But they still get screened from a cardio standpoint before they ever get put on that, hopefully. So.
Where does the arrhythmia start when you start escalating?
Well, QT intervals are a very fluid thing, and it's influenced by heart rate. As the heart rate slows down, the QT interval gets longer. So anything that causes bradycardia will, in event, prolong the QT interval a little bit. But when you have something that works on the electrical channels in the heart, Ibogaine is a potassium channel blocker, which is very involved in repolarization of the heart. But anything that does that, you have to be worried. And with things that affect the QT interval, it's not like a 2 + 2 = 4 issue. It's like a 2 + 2 = 8 issue, because things are agonistic. Like when you have several different factors in a patient that can prolong the QT interval, it starts to add up and multiply. So you really, no matter what the dose, have to make sure that there's no genetically prolonged QT intervals, and look at their heart rate. And QTC is actually a more accurate predictor, because that's the QT interval adjusted for the heart rate. That's what we pay more attention to generally. Next slide. So this was the lowest dose that I found in the medical literature. This was from Dr. Alper's fatality study, a 40, let's see, what year was this case? This occurred in 1990. So this is one of the older cases. Okay. So this person was witnessed to become unresponsive about 4 hours after her treatment. Past medical history of hypertension, and she had an abnormal EKG documented 3 months prior to death. So this lady, I wouldn't have touched with a 10-foot pole, because hypertension is the single biggest risk factor for coronary artery disease. If people walk around with uncontrolled hypertension, they're setting themselves up for heart attacks later in life. Because basically high blood pressure makes the heart work harder. It increases the workload on the heart. In her abnormal EKG, she had inverted T waves on her 12 lead 3 months prior. That's an indication to someone that there was definitely some cardio damage. So, I would be interested to know who actually looked at this lady's 12 lead EKG and then just okayed her for Ibogaine, because that would have been a big clue. If I had seen that EKG, they would have had to have a stress echo before I would touch them, because that's the only way to really confirm. And then that would have probably saved this lady's life, because she would have probably failed her stress test, because on her autopsy she had 3-vessel coronary artery disease. There's only 3 coronary arteries, so she had blockages in all 3. She definitely wouldn't have passed a stress test and wouldn't have received Ibogaine. She would have actually received stents or open heart surgery, and it would have saved her life. So that's like an ulterior motive of aggressive cardiac screening, is catching people before they have their heart attacks.
So just to clarify, this was a provider setting?
Yes, this was at a treatment.
This is a Swiss psychiatrist, and he didn't really believe in using necessary to have screenings.
So he learned the hard way, I guess. Oh, that's my next case study. There's the other one, yeah. It's nice to have the historians here chiming in on that. Next slide, please. So next study is another one. This was from 2002. This occurred in 2002. So this lady was not feeling well the day before. Toxicology is unknown, but she, on her autopsy, had congenital heart defect and moderate coronary artery disease. Congenital heart defects are the most common type of birth defect. A lot of people walk around with them not even knowing they have them, because a lot of congenital heart defects can be so mild that they may never cause symptoms until they cause their first cardiac event. So, you know, this is another case where if someone tells me that they had a hole in their heart or a murmur or something, obviously that needs further investigation. And I did pediatric cath lab. I did a lot of diagnostic procedures on children with congenital heart defects. I wouldn't touch that with a 10-foot pole with Iboga either. So, because their hearts are just really jacked up. Congenital heart defects, they can involve the walls of the heart, the valves of the heart, and the arteries and the veins around the heart. So it affects pulmonary circulation. It affects a lot of things. 2015, Lancet did a study. They estimated that CHD was present in 48.9 million people globally as of that year. Also, congenital heart defects resulted in 303,300 deaths that year. It's a big killer that a lot of people aren't really aware of. Unless they work with these kind of kids or have someone in their family that has heart defects. It increases the chances of developing other heart issues, primarily arrhythmias. Congenital heart defects do set you up for arrhythmias, pulmonary hypertension, congestive heart failure, infective endocarditis, and coronary artery disease as an adult. These kids are born with the odds stacked against them. Next slide. So recommendations, obviously aggressive screening and assessing for exclusion criteria. These are some of the exclusion criteria listed. Screening for heart disease and risk factors for heart disease. The top risk factors in this order that most commonly affect heart disease would be hypertension, high blood pressure, diabetes, high cholesterol, smoking, family history, and lifestyle and diet. And most of those factors are somewhat controllable for people, but some of them are not. You can't really beat genetics, and some people have genetic high blood pressure. That's another person I wouldn't really want to go near with Iboga either. And then you're also looking for healthy liver, healthy kidneys, any psychiatric issues. Seizure disorder would obviously be a big exclusion thing too. And we've got a lot more things listed in clinical guidelines. This is just kind of the short list. Next slide. So myth number 4, after the psychotropic effects wear off, one is safe from adverse events. Monitoring afterwards is just as important as the pre-process and preparation process. The Dr. Alper's study showed the mean time for problems was actually 12 to 24 hours after Ibogaine, and there's some other evidence that noribogaine may be the bigger culprit, that a lot of these fatalities are quite possibly happening as the body converts Ibogaine to noribogaine, and you stack up a bunch of each in your system. Several deaths have occurred as significantly later than time of ingestion. All of these were pulled from Dr. Alper's fatality study. Well, because noribogaine is also a QT prolonger. And there's one case in particular where they did a lot of pharmacokinetics on a patient who had an adverse event and survived, and they realized when his noribogaine peaked was when he had the most issues with heart arrhythmias. And then Ken, years ago, kind of hypothesized that this could be the issue as well. Dr. Alper's study was 19 patients. And then I looked at Koenig's study after that, the 2015, which added, I think, 10 more. And then there's been about 4 more journal articles put out in the last 2 years since the 2015 study. So it equaled 34 cases. All right, next slide. So case study number 1, 25-year-old male, self-administered 2.5 grams of Ibogaine over 3 hours under supervision of his mother. This case kind of makes me sad as a mother because I'm sure this mother was completely traumatized by this. The past medical history was chronic heroin addiction, and he had a history of an arrhythmia. He had supraventricular tachycardia. So once the heart is capable of going into abnormal electrical pathways, it's always capable of going back into abnormal electrical pathways. So this is another person that shouldn't have been doing it, and probably not even under medical supervision. I doubt any medical people would have touched him. So he had respiratory difficulty, progressing to cardiopulmonary arrest and heart failure. He had some other weird symptoms. He obviously, they said he experienced hallucinations, ataxia. He had muscle spasms, weakness, fever, and urinary retention that day. And most of it resolved except for the spasms and ataxia. And then that's when he arrested. He displayed signs of a severe brain injury. He was in the decorticate position, which is they kind of get their arms clenched up on their chest and their palms clenched up. And from a neuro standpoint, that's an extremely bad sign that, it's definite irreversible brain death. So they withdrew care, or he died. They didn't actually withdraw care, but his organs started failing one by one. He went in, most likely my theory is he went into cardiogenic shock after his arrest, and probably kidneys, liver, everything just started shutting down within a very short amount of time for a healthy 25-year-old who really only had one history of SVT. Next slide. So this is a 2005 case. This lady, 48-year-old, 15 milligrams per kilogram at a treatment center. She had a past history of polysubstance abuse. For me to count them as polysubstance abuse, I said they only needed to abuse 2 separate things. Fibromyalgia and gastric bypass 8 months prior. She had lost 61 kilograms since her gastric bypass surgery 8 months prior. And also gastric bypass surgery changes the way you digest and metabolize things because things bypass your stomach. They don't get broken down as much by the hydrochloric acid in your stomach, and they go straight into your small intestine. So it's actually a common problem that they're noticing now with patients who've had gastric bypass. A lot of them are at risk for alcoholism because they give them gastric bypass, but they don't treat their food addiction. And when they drink, it goes straight into their gut. It makes them drunker, faster, for longer, on less alcohol. So it kind of sets them up for being very easily altered, and that's a big issue. Her benzodiazepine, she died at her treatment facility, but her toxicology was positive for 3 different benzodiazepines, and she didn't tell her providers that she was on benzos. That's kind of common too. A lot of people taking benzos don't realize how serious benzos are and often forget that they're on. They just tend to conveniently forget that they're on benzos when it comes to giving you their medication list, and you don't realize until you drug test them sometimes. This is a great argument for drug testing, all clients across the board every single time, because people are going to fall through the cracks, and you can't really trust a person's word about their use. Everyone downplays their drug use in general. Exactly. Yes. It's extremely important, and there are a good amount of providers that still don't want to practice that because they feel like it's too much like a rehab center or too medical or whatever, but it's a safety measure. It's for the provider's safety and it's for the patient's safety. You have to know if there are drugs in their system because Ibogaine can potentiate those drugs. Yes. Well, she didn't tell them she was on benzos. And obviously they didn't drug test her until after this. So, she could have quite possibly, I'm just speculating, but she could have quite possibly had a seizure. Also, her death was actually related to acute coronary syndrome, which is a fancy medical word for a heart attack. So she had coronary artery disease. I'd be interested to see what her 12 lead looked like as well and what her cardiac risk factors were. It just wasn't available in the medical literature, really. Yes?
I know that a lot of times on stick tests there are false positives and false negatives.
Yes.
Is that particularly true for benzos?
There are, there's one type of benzo that is a false negative. Sometimes it doesn't show up on certain drug tests. And it escapes my mind which one that is. Right. Yeah, I mean, that's the gold standard. But really, there's kits you can buy in pharmacies now. Like you can walk into a CVS and buy something that tests for 10 plus different drugs. And then, yeah. So, I mean, it's fairly cheap. You always want to test your people first thing in the morning when the urine is most concentrated because they can drink a lot of water and dilute their drug test to lower than detectable levels. And it kind of needs to be a surprise so they don't get to bring in synthetic urine or anything like that. It needs to be supervised collection as well because of there are people out there that use synthetic urine to beat their drug test with their probation officers and that kind of thing. So that's... Oh, yeah. That's what I'm saying. The home tests are almost as correct as an actual lab test. So, a lot of parents use them on their teenagers and that kind of thing. It's kind of weird. But she had acute coronary syndrome. So obviously she had sudden cardiac death due to a pre-existing heart condition that also wasn't caught during screening. This is to emphasize that screening is a big deal. Okay, that's it. And then, next slide. Yeah, okay. Coronary artery disease also is the number one cause of sudden cardiac death. So majority of heart patients get their diagnosis during their first heart attack, but only about 50% of people survive their first heart attack, their first cardiac arrest. So it's a double-edged sword where screening could possibly catch some of these things before it leads to a cardiac arrest. Recommendations, obviously you need to monitor people for 3 full days after ingestion. You need to monitor them closely, take vital signs, level of consciousness, maintain a calm environment, and support their mental state. A lot of them come out of this distressed and need support. Rehydration is very important. Some people go 24 hours or more without being able to eat or drink, and they've vomited and defecated and urinated, and they're losing electrolytes with all of that. So when you have a lot of electrolytes going out, as soon as they're able to eat and drink again, you need to start putting a lot of electrolytes back into them because, noribogaine is also an issue. So the aftercare, rehydration is very important. Next slide. So other notable correlations, just from my counting from my nursing notes, 12 of the 34 cases positive toxicology, 10 pre-existing cardiopulmonary disease. 12 of them had no cardiopulmonary disease or history, but in all of the 12 cases with no cardio disease or history, they were notable either for positive toxicology, self-administration, or electrolyte abnormalities that induced the arrhythmias. 21 of these cases involved arrhythmias, sudden cardiac death, or acute heart failure. So obviously, cardiac is the biggest issue, the biggest safety issue we're up against with providing safe treatments. 5 had liver disease. 3 of the deaths were psychospiritual. Would have been 4 because one of them was a covert detox attempt. They went to a psychospiritual center and didn't tell them they were there to detox. But 3 of the 3 psychospiritual cases, 2 of them had the major pre-existing heart conditions. It was the 2 low-dose ladies from the earlier years. And the 3rd psychospiritual death had a normal EKG 9 days before treatment, but on admission to the hospital had electrolyte imbalances. She had low potassium, magnesium, and calcium. So there you go. All 3 of those affect the heart. Yes? No, there are several cases. More the people with no cardio disease. A lot of those were more self-administration, positive toxicology. So there were flaws in the system, where they weren't drug tested beforehand, or their screening wasn't as up to par as it could have been, and that kind of thing. So most of the no cardio disease deaths were like electrolyte issues. So we really need to tank people up before treatments and have them going into treatment with very high normal electrolyte values. You don't want them high because that can cause issues too, but you want them on the high end of the normal value range because you're guaranteed to lose some electrolytes during this process. There's really no way around it because you lose electrolytes every time a fluid comes out of your body. Yeah. Yeah, and yeah. But still, yeah, and that's the thing. Hearts are very unpredictable. So, cardiologists kind of like to talk about hearts as this very unpredictable thing, and they almost always refer to hearts as women. we talk to the hearts as her, and that kind of thing. But and I was teaching my webinar course, and I was talking to them about ventricular arrhythmias, and I was like, heart is like, being from the South, I'm familiar with passive-aggressive women. But being from the South, they say, a cardiologist I used to work with says, the heart's just like a passive-aggressive woman, You know she's mad, and you keep asking her, and she's like, I'm fine. And then all of a sudden, she's not fine, and she blows a little gasket on you. And that's what happens when the ventricular pacemaker takes over, and you get these lethal cardiac arrhythmias. The heart is designed to never stop beating. It beats all day, every day, until you die. So it's designed not to show that there's a problem until it's a really big problem. It's usually more than one factor in each death. It's never a straightforward took Ibogaine, heart stopped kind of thing. It's took Ibogaine, this history, this electrolyte status, this QT interval, that kind of thing.
Can we
about that one.
Can we finish your presentation and then just have
Next
a few
slide.
questions?
This is the last slide. So clinical guidelines obviously is a good starting point for providers to look, but it's because it's a public open document. It's a little watered down and generalized. You can get a lot more specific than that. Guidelines work well when things are black and white, but detox medicine is always gray, and your clinical judgment is more important. That's where experience and assessment skills and clinical judgment skills come in. That's something that your medical people can offer. And in countries with legal status, it would be great to start establishing very firm minimum standards of care and training programs for providers and prescribers and things like that. and research teams, because I think that's the only way to go as far as minimizing risk and safety, is to start working more towards legalization so that we can set up more minimum standards of care around this plant. And that's it. Thank you.